I will discuss the topic called anti-diabetics. So what is diabetes and what are the drugs which are used in the treatment of diabetes? So, diabetes mellitus. So diabetes mellitus is a condition where there occurs increased blood glucose level. So because of the over metabolism of the carbohydrates, there occurs glucose synthesis, and if there is any elevated glucose level than it's normal, it leads to a condition called as diabetes mellitus. And this diabetes mellitus is characterized by the metabolic as well as vascular disorder. So on chronic diabetes conditions, it leads to the metabolic abnormalities as well as vascular abnormalities, and this is a disorder of carbohydrate metabolism. On excessive carbohydrate metabolism, it leads to diabetes. There are two types of diabetes. First one is type 1 diabetes, that is insulin dependent diabetes, as well as type 2 diabetes, insulin non dependent diabetes. So type 1 diabetes is a juvenile diabetic condition. So here this occurs in the children or infants, and it leads to a loss of, it is characterized by the loss of pancreatic beta cells. So if there is any destruction to the beta cells of pancreas of islet Langerhans, from where the insulin is secreted, then it leads to the type 1 diabetes, and thereby there occurs decreased insulin, and this is insulin dependent type. The other one is type 2 diabetes, which occurs mostly in the adults, and this is because of the defective signaling pathway in the insulin. So in this insulin signaling pathway, if there is any destruction or disturbances, then it leads to type 2 diabetes condition, and this is non-insulin dependent. And in the early stages of this type 2 diabetes, it is treated through diet or through oral hypoglycemic agents, and in the later stages we have to give insulin therapy. Here is a diagrammatic representation of insulin signaling pathway, where the insulin is binding to the insulin receptors, and there are two subunits of the insulin receptors, alpha receptors and the beta receptors. So the alpha subunit contains the binding site of the insulin, as well as beta subunit contains the tyrosine kinase binding. So here the insulin, once it binds to the alpha subunit, there occurs the stimulation of the beta subunit, and thereby their phosphorylation of the enzyme takes place. So once the phosphorylation of the enzyme takes place, it either enters into the kinase signaling pathway or the PI3K signaling pathway. So on the phosphorylation of the enzymes, there occurs two signaling pathways. On the activation of the beta subunit, there occurs the kinase signaling pathway, which is involved in the cell growth and gene expression, whereas the other signaling pathway, which is triggered by the metabolic functions. So this signaling pathway is triggered by the metabolic functions, whereby it aids in the synthesis of lipids, carbohydrates, proteins, and causes cell survival and proliferation. So here we have GLUT4 transporters. These are the transporters which aid in the entry of the glucose into the plasma membrane. So here once the glucose, once it is entering through passive diffusion. So passive diffusion is a mechanism by which the movement of molecule takes place into the cell with the utilization of energy. So here the glucose is entering into the plasma membrane with the through the GLUT4 transporter, and once the excessive glucose, it is getting converted to the glycogen. It is converting to the glycogen, and it is stored in the form of glycogen. And once if there is any necessity of the glucose, this glycogen is getting lysed, or else this glycolysis takes place, and thereby the glucose is utilized by the mitochondria to produce energy. So these are the symptoms of the diabetes, where it may cause polydipsia, where that is severe thirst, and polyphagia, that is severe hunger, and lethargy. There occurs weight loss, and there will be nausea, vomiting, and there will be blurred vision. And if we observe the breath of the diabetic patient, there occurs the smell of the acetone. The acetone smell can be observed in their breath. So this is because of the secretion of the ketone bodies in the body. So the excessive secretion of the ketones which are occurring in the body, that gives the acetone smell in their breath. Glycosylated hemoglobin. So what is this glycosylated hemoglobin? So glycosylated hemoglobin is a type of hemoglobin which is used to observe the elevated glucose levels in the plasma. So this glycosylated hemoglobin test is used to monitor the plasma glucose levels. So here these are, these tests are mostly conducted for every 4 to 6 hours in order to monitor the glucose levels in diabetic condition. And insulin which is there, the insulin which is secreted, it is promoted by increased blood glucose levels, amino acids, as well as GI hormones. What is insulin? So insulin is a beta cell secrete due to high blood glucose levels. So insulin is a hormone, it is a peptide hormone which is secreted by the beta cells of islets of Langerhans on response to the increased blood plasma glucose. And this glucose uptake, this insulin, it allows the glucose uptake into the tissue and thereby where the glucose levels can be reduced. So the uptake of glucose into the tissues is increased, thereby the plasma glucose concentration can be decreased. And glucagon is a compound which is secreted by the alpha cells of islets of Langerhans when there is a blood glucose level is low. So if there is any lower blood glucose levels, then this glucagon is secreted by the alpha cells, and glucose is released from the tissues back into the blood. So once on release of this glucagon, the glucose can be repacked into the blood circulation again. Here is the mechanism where through the GLUT2 as well as GLUT4 transporters, the glucose is entering and the glucose is converted to ATP. So through the glycolysis cycle, the glucose is converted to ATP, that is energy, and this ATP is utilized for the depolarization of the cell, whereby the potassium ions exit out of the cell and thereby the calcium entry takes place. So because of the calcium entry, there occurs depolarization of the cell, and there from where the insulin is secreted into the blood circulation by the process of exocytosis. Proinsulin. First, the insulin, proinsulin, which is an inactive form of insulin, it is converted to insulin as well as the peptide C. And this is a storage hormone which promotes anabolism. So this is a storage hormone which aids in the metabolism of various carbohydrates, proteins and lipids. And it inhibits the catabolism of carbohydrates. So here, the anabolism in the sense formation of the compounds, and catabolism in the sense breakdown of the compound. So this insulin, it inhibits the breakdown of the carbohydrates. So whatever the carbohydrates which we intake, these complex carbohydrates are a breakdown to simpler carbohydrates, that is glucose. So it inhibits the formation of the glucose and thereby preventing the catabolic reactions of the carbohydrates, proteins as well as fatty acids. So in the absence of insulin, so if there is any absence of insulin in the body, then the glucose cannot be, in the sense there occurs more carbohydrate as well as fatty acid metabolism, and thereby the glucose uptake into the tissues will be less, and thereby the blood glucose level will be increased. Here we can see the mechanism of action, whereby the insulin is binding to the insulin receptors and it is converting the glucose, whatever the glucose which is entering into the cell, to the glycogen. Let us see the pharmacological actions of this insulin. So on liver, what does this do? Insulin, it converts the glucose to glycogen in the liver. So it increases the storage of glucose in the liver in the form of glycogen, and it inserts the GLUT2 glucose transport molecule into the cell membrane. So what does it do? This insulin, it aids in the synthesis. It promotes the gene expression of the GLUT receptors, and thereby it sends the GLUT2 as well as GLUT4 receptors to the plasma membrane, again aiding in the formation of these transporters, and it inhibits gluconeogenesis, that is the formation of glucose from proteins and carbohydrates apart, proteins and fatty acids apart from carbohydrates. and it decreases the protein catabolism. It prevents, we can say it decreases or prevents the breakdown of the proteins into amino acids. So here is a pictorial representation where the glucose is entering into the liver through the glucose transporters, and it is stored in the form of glycogen. And here in the pancreas, from where the insulin is secreted, and thereby it stimulates the glucose uptake into the tissues. So what does this insulin do on muscles? So this insulin, it stimulates the glycogen synthesis and protein synthesis. So in the muscle, it aids in the synthesis of glycogen and proteins, and thereby there occurs increased muscle tone, and the muscle tone will be built up, or as we can say the muscles can be built up. And the glucose transporter into the cell is facilitated by the GLUT4. In the liver, it is facilitated through GLUT2 transportation, but in the muscle, it is aiding through the, or else the glucose entering into the cell is aided through the GLUT4 transporter, and it inhibits the protein catabolism. Here is the mechanism, pictorial representation, where through the GLUT2 receptors the glucose is entering into the cell, and in the cell, in the presence of insulin, the GLUT2 vesicles they fuse with the plasma membrane and aiding in the glucose uptake into the tissue. What does this insulin do in the adipose tissue? So in the adipose tissue, it aids in the storage of triglycerides. As I told you, it increases the carbohydrate, protein and fatty acid synthesis. So whatever the fatty acids which are synthesized, they are stored in the form of triglycerides in the adipose tissue, and this is a mechanism which is taking place again through the GLUT4 receptors. So here, in the adipose tissue, that fatty acids are stored in the form of triglycerides. So here, whenever the fatty acids are necessary, there occurs the lipolysis, or else there occurs the lipolysis of the triglycerides, and whereby these triglycerides are converted to free fatty acids as well as glycerol. So whenever the glucose is necessary, these triglycerides get break down, and thereby the glycerol is released into the blood circulation. Now let us see what is insulin. So insulin is a peptide hormone which is containing 51 amino acids. So these 51 amino acids are present in two chains. One chain containing 21 amino acids and the other chain containing 30 amino acids. And these two chains are bound with a disulfide bond. So they contain these two sulfur binding atoms, and these two chains are bound by the disulfide bond. And this is not active orally. So if we give insulin through oral route, it is not active. So that is preferably to give through IM route or IV route. And inactivated by insulin is found mainly in the liver and the kidney. So this insulin is inactivated by an enzyme called as insulinase, and which is mainly this insulinase is mainly found in the liver and kidney, and this is dose dependent. So in the renal insufficiency, if there is any renal failure or renal related disorders, the insulin dose should be regulated. And this insulin is human insulin is a source of bovine. So from bovine or from beef pancreas or pork pancreas, this insulin is prepared synthetically. Let us see what is human insulin. So human insulin is a recombinant gene expression. So this is synthesized by the recombination gene expression method, and this do not contain measurable amounts of proinsulin. So this human insulin is an active insulinated form, and it is containing diminished antibody. So they contain diminished antibodies in their preparations. They are less allergic reactions. They provide less allergic reactions as well as they provide less lipodystrophy. So lipodystrophy is a condition where there will be difficulty in the proper lipid functioning or lipolysis, and it is preferred it is mostly preferred in the diabetic condition. What are the various insulin preparations? So there are various insulin preparations available in the market. They are in these preparations, they are rapid acting, short acting as well as intermediate acting also. So rapid acting insulin preparations are Lispro, Aspart and Glulicin, and the short acting insulin includes the regular insulin which is in the crystalline form, and the intermediate acting insulin includes NPH, that is isofan, and lente insulin, that is in the zinc form. And long-acting insulin includes ultra-lente, detimor as well as glargine. These are the marketed formulations of insulin. If we see the pharmacokinetics of these insulin preparations, these rapid acting drugs have the onset of action of 5 to 15 minutes. So once administered, after 5 to 15 minutes, they exert their action, but the peak action is observed at 30 to 60 minutes after administration, and the duration of action is about 2 to 5 hours, and these can be injected before the meal. So before starting the meal, these rapid acting insulins are mostly given. And short acting insulins are having the onset of action for about 30 minutes. So after administration of 30 minutes, they show their action, and the peak action is observed at 1 to 3 hours after administration. And the duration of action, the effect of these insulin preparations long for about 4 to 8 hours, and these are injected almost 15 to 30 hours before the meal. And the intermediate acting insulin, the onset of action, so in the intermediate acting insulin, the NPH, that is lente, have the onset of action of about 1 to 2 hours, whereas ultra lente, they have the onset of action of 2 to 3 hours, and the peak action is observed at 4 to 8 hours after administration, and the duration of action of NPH is for about 8 to 12 hours, and for ultra lente it is for about 8 to 24 hours, and these are used to control the glucose levels. These are used to control the glucose levels when they are administered in between the meals. So they are to be given in between the meals, and they can be combined with short acting insulin preparations in order to show better effect. And the long acting insulins have the onset of action of 30 to 60 minutes, and the peak they don't have any peak observation, because once they administer, they exert their actions very effectively, and the duration of action lasts for about 16 to 24 hours, and they are taken once a day. Because of the long duration of action, they are preferred to take once a day. These insulin preparations are used mainly in diabetic mellitus condition, and they are used to treat diabetic ketoacidosis. So this is a condition where there will be release of the ketone acidic bodies in the body. There will be excessive secretion of the ketone acidic bodies and a hyperosmolar coma. So this is a condition which is occurred because of the increased osmotic pressure. So because of the high glucose concentration in the body, there occurs dehydration. So this dehydration is occurring because of the high osmotic pressure. So because of the excessive osmotic pressure, the movement of molecules is taking place from inside to out of the body, leading to dehydration. So this condition is called as hyperosmolar coma. The adverse effects of insulin: if the insulin is secreted overly, or if the insulin preparations are given on chronic use, it may lead to hypoglycemic conditions, it may lead to severe allergic reactions, it may lead to lipodystrophy, that is there will be a problem in the metabolism or catabolism of the lipids, and it may lead to seizures and coma. Now let us see the drugs which are used in the treatment of diabetes. So these are called as oral hypoglycemic agents, and the drugs include sulfonylureas, and in the sulfonylureas there are first generation drugs and second generation drugs. The first generation drugs include the drugs like tolbutamide and chlorpropamide, and second generation drugs include the drugs like glibenclamide, which is also called as glyburide, glipizide, gliclazide as well as glimeride. And the other category of drugs include biguanides. The drug which come under this category is metformin, and there are phenylalanine analogs or meglitinides. The drugs include ripaglinide as well as nataglinide, and thiazolidinediones. So thiazolidinedione derivatives like rosiglitazone and pioglitazone, and alpha glucosidase inhibitors like meglitol and acarbose. So these are the various oral hypoglycemic agents used to treat diabetes. Now let us see the pharmacology of these drugs. Sulfonylureas. If we see the sulfonylureas, the generalized structure of sulfonylureas, they contain the sulfur with double bond oxygen group. So they contain the sulfur with two oxygen groups combined to the sulfur atom with the double bond. So this is the characteristic group which is aiding in the anti-diabetic activity of this sulfonylureas, and these are the agents which promote the release of insulin from the beta cells. So they aid in the release of the insulin from the beta cells. So, if we see the mechanism of action of these sulfonylureas, they bind to the sulfonyl receptors which are present on the plasma membrane, and once they on binding to the plasma membrane, it aids in the potassium intake, and thereby there occurs depolarization of the cell. So once the sulfonylureas bind, they aid in the synthesis of ATP, and this ATP is utilized for the release of the insulin from the beta cells by the process of exocytosis. So here on the binding of sulfonylureas to the receptors, it aids in the production of ATP, and thereby there occurs exocytosis and insulin is released from the beta cells. Let us see the pharmacokinetics of sulfonylureas. These are mostly given through oral route, and they are well absorbed through oral route, and they are 90% plasma bound. So they bind to the plasma membrane, they bind to the plasma proteins, and this binding capacity is about 90%. That is the reason they show low volume of distribution. VD is nothing but volume of distribution. Because of the binding to the plasma proteins, they can't distribute it equally all over the body, and they are excreted unchanged in the urine. Because of the binding to plasma proteins, they don't undergo metabolism, and thereby they are excreted unchanged. These sulfonylureas are having various drug interactions. So there are few drugs which enhance the action of sulfonylureas, and there are few drugs which inhibit the action of sulfonylureas. So the drugs which enhance the action of sulfonylureas are the drugs like phenylbutazone, sulfenpyrazone, salicylate, sulfonamides, and para-amino-salicylic acid. So these are the drugs which displace from the protein binding. So here what does they do, as these sulfonylureas are 90% plasma bound, so these are the drugs, they won't allow the sulfonylureas to bind to the plasma proteins, and thereby if they won't bind, they are available in the systemic circulation, thereby their action is enhanced. And the drugs like cimetidine, sulfonamides, warfarin, chloramphenicol, acute alcohol intake, so these all, they inhibit the metabolism as well as excretion of sulfonylureas. So if these sulfonylureas are not metabolized, thereby they are available in the systemic circulation, and thereby their action is enhanced. And the drugs like salicylates, propranolol, sympatholytic hypertensives, lithium, theophylline, and alcohol. So these are the drugs which show synergistic action with the sulfonylureas. The drugs which decrease the action of sulfonylureas are the drugs like phenobarbital, phenytoin, rifampicin, chronic alcoholism. So these are the drugs which promote the metabolism of these sulfonylureas. So if they are once metabolized, they get excreted out of the body, and thereby they are having less effect. And the drugs like corticosteroids, diazoxide, thiazides, furosemide, oral contraceptives. So these are the drugs which suppress the insulin release. So these won't allow the sulfonylureas in order to release the insulin from the beta cells. So they suppress the action of this insulin, they suppress the release of the insulin from the beta receptors. So, these sulfonylureas on long-term usage, they shows adverse effects like hypoglycemia, hypersensitivity reactions, and the common side effects like nausea, vomiting, flatulence, diarrhea or constipation, headache, as well as weight gain. The other category of drugs are bigonides. So the general structure of bigonides is like they contain the nitrogen NH2 groups which are attached, which are structurally representing the straight chain. So the drug which come under this category is metformin, which is available in the market as glucophage. So this is a drug which does not cause hypoglycemia, because this does, on long-term usage also it does not cause hypoglycemia, and it produces significant decrease in the triglycerides and LDL levels. So these triglycerides, if this triglyceride breakdown takes place, then it leads to the, if the triglycerides are formed more, then it leads to the breakdown of these triglycerides to glycogen, glycerol as well as glycogen. So this glycerol is converted to glucose again. So this metformin, it reduces the level of triglycerides as well as LDL, and it increases the HDL levels. And lactic acidosis is observed if we give metformin if there is any renal failure. Here, the mechanism of action of metformin is that it suppresses the hepatic gluconeogenesis. So, gluconeogenesis is a formation of glucose from the fatty acids and proteins. So, this metformin, it suppresses the process of gluconeogenesis, thereby inhibiting the formation of glucose from the fatty acids, and it enhances the insulin-mediated glucose deposit. So, it allows the glucose to enter into the tissue, or else it allows the glucose to get converted into glycogen by uptake mechanism of the glucose. And this, what does it do with this metformin? It retards, or else we can say it impairs the reabsorption of glucose. So this metformin, it won't allow the glucose to get absorbed into the intestine. Not only glucose, it won't even allow the reabsorption of the other amino acids, vitamin B12 and hexoses, and it interferes with the mitochondrial absorption chain. So here in the gluconeogenesis process, the mitochondria, the mitochondria is involved in the production of ATP. So this chain is we can say this chain is breakdown, or else it interferes with the breakdown of this mitochondrial absorption chain. So here is the diagrammatical representation of the gluconeogenesis pathway. Here this is the glycolysis cycle, where from the glucose the ATP is produced, and here this metformin, it interferes with the gluconeogenesis process, and thereby preventing the formation of the glucose. This metformin, on chronic usage, it causes adverse effects like lactic acidosis. So it increases the lactic acid content in the body, and it causes vitamin B12 deficiency, because it won't allow the vitamin B12 to get absorbed into the intestine. Thereby it leads to vitamin B12 deficiency, leading to the megaloblastic anemia. And it causes the common adverse effects like nausea, abdominal pain, anorexia, and it causes metallic taste, and it causes mild diarrhea and fatigue. The other category of drugs are phenylalanine analogs, or meglitinides. So these meglitinides, they lower the blood glucose level by stimulating the pancreatic secretion of insulin. So here, by stimulating the beta cells of islets of Langerhans, it allows the stimulation of the pancreas, leading to the secretion of the hormone out of the pancreas. And this meglitinides, they can either be given individually or in combination with metformin to show better effect, and it should not be taken before or up to 30 minutes of the meal. So after the meal, it has to be taken after 30 minutes of the meal, and it should be taken either before 30 minutes or after 30 minutes of the meal, and the dosage is depending based on the food intake. So the dose of this metformin should be given based on the intake of diet what we take. The other category of drugs are thiazolidinediones. So these thiazolidinediones, they act on the PPAR gamma receptor. So these are the peroxisome proliferative activated receptors. So peroxisome proliferative active receptors, they aid in the the stimulation of these receptors, aid in the glucose and lipid metabolism. So here the glucose and lipid metabolism takes place, whereby the glucose is getting breakdown, and it enhances the sensitivity of the insulin which is present in the muscle to the GLUT4 transporters. Here if we see the mechanism of action pictorial representation, here are the PPAR receptors. It has the affinity, or as we can say, it allows the metabolism of the glucose. When these PPAR receptors are getting stimulated, the RXR receptors, they get bind, and thereby when these RXR receptors are stimulated, it causes gene expression whereby the ribosomes are formed, and these ribosomes, they aid in the protein formation. So here these PPAR receptors, once they get activated, they cause the glucose metabolism, and thereby the glucose is getting degraded to produce energy. These thiazolidinediones, they decrease the triglyceride levels as well as they decrease the serum lipids. So this is a characteristic feature of these thiazolidinediones. They decrease the triglycerides as well as LDL levels, but they increase the HDL levels. And the trioglitazone, the drug which come under this category of thiazolidinediones, it is associated with the hepatitis. So on long-term usage, it may cause hepatitis and edema. Alpha glucosidase is an enzyme which converts the dietary carbohydrates to the simpler sugars. So these simpler sugars are nothing but the glucose. So here these alpha glucosidase inhibitors, they inhibit the enzyme of alpha glucosidase, whereby the glucose formation is inhibited, and it reduces the absorption of glucose into the tissue after the meals. So after we take the glucose is formed, or whatever the glucose is formed, they won't allow the glucose to get uptake into the tissues. But there is the side effect. The side effects which are associated with these drugs are flatulence and diarrhea. There are the newer category of the drugs. There are newer approaches for treating diabetes. The drugs which come under this category are exenatide, sitagliptin, and pramlintide. Exenatide. So here this is a drug, we can say this is a GLP-1 analog. So GLP-1, glucose lipolytin analog. So this GLP-1 analog. So GLP is an incretin which is released from the small intestine. So this is an incretin which is released from the small intestine. But this GLP is susceptible to the metabolism by the enzyme called as DPP4. So DPP4 is a DPP is a dipeptidyl peptidase 4 enzyme. So this GLP, once it is released from the small intestine, it undergoes metabolism by this dipeptidyl peptidase 4 enzyme, and thereby it is not effective. So this GLP analog, that is exenatide, is a GLP-1 analog which is resistant to this enzyme, and thereby they act on the insulin. They allow the insulin to secrete from the beta cells, and thereby they aid in the decreased glucose levels. And this exenatide, it suppresses the glucagon release and reduces the appetite. So this whatever this drug is there, it won't allow the glucagon to get released, and thereby if the glucagon is not released, the glucagon is not converted to the it won't allow the glucose to get metabolized. It won't allow the carbohydrates to get metabolized, and thereby the appetite can be reduced, and it is administered through subcutaneous route. So here we can see the pictorial representation. The incretins which are released from the small intestine, they stimulate the insulin release. So these GLP, they stimulate the insulin release and they inhibit the glucagon release. So here that is the ultimate motto is the lowering of the blood glucose levels. So here but this GLP, whatever is there, it is metabolized by the dipeptidyl peptidase enzyme. So here this exenatide is an analog of this GLP-1, whereby it stimulates the insulin release and thereby the blood glucose level is lowered. And sitagliptin is a drug which inhibits the enzyme DPP itself, and thereby if DPP enzyme is inhibited, thereby the GLP protein is not metabolized and the insulin stimulation is the release of insulin is stimulated. Sitagliptin is an oral anti-diabetic drug which is acting by inhibiting the enzyme called dipeptidyl peptidase 4, and it potentiates the secretion of the insulin from the pancreas and thereby lowering the blood glucose levels. The other one is a glucagon. So glucagon is a single chain polypeptide containing 29 amino acids. So glucagon is a single chain polypeptide which is having 29 amino acids, and it is having a molecular weight of 3500 daltons, and this is obtained from beef and pork glucagon, and this is obtained from the beef and pork, and thereby the human glucagon is prepared. So if we see the mechanism of action of this glucagon, it is acting through GPCR receptor. So on this glucagon, if it binds to the GPCR receptors, it is allowing, or as we can say, it is allowing the conversion of GTP to GDP, thereby the cyclic AMP levels are increased. So if the cyclic AMP levels are increased, there occurs the decreased secretions. If we see the pharmacological actions of the glucagon, it shows positive inotropic and chronotropic effect. So inotropic effect in the sense increased force of contraction, increased heart rate, and chronotropic effect is the increased force of contraction. So it shows positive effect on these both, and it enhances glycogenolysis in the liver. So it allows the glycogen to break down into glucose, and it is mainly aided in the development of the diabetic ketoacidosis. So if glucagon action is more, then it promotes the diabetic acidosis. The ketone bodies are formed more in this condition, and it inhibits the gastric acid secretion. This glucagon is inactive orally, and it is preferred through IV route, and the T half of this in glucagon is about 3 to 6 minutes. It is mainly used to treat hypoglycemic conditions and cardiogenic shock, and it is used in the diagnosis of pheochromocytoma. So this is a condition where there occurs the inflammation of the adrenal gland. Here we can see the tabular format of anti-diabetic drugs. So the drug, like the drug tolbutamide, it is having a T half of about 6 to 8 hours, and the duration of action, the duration of action of this drug lasts for about 6 to 8 hours, and it is cleared, or else it is excreted through liver, and the dose which is given is about 0.5 to 3 gram. 3 gram for and it is given at the 2 to 3 doses. The daily doses are about 2 to 3, and each dose is containing about 0.5 to 3 grams. And the other drug is chlorpropamide, which is having a T half of about 30 to 36 hours, and the duration of action of this drug is about 36 to 48 hours, and it is excreted, or else it is cleared from the body through liver as well as kidney, and only one dose is given per day at the dose of 0.1 to 0.5 grams. And the other anti-diabetic drug is glibenclamide. It is having the T half of about 4 to 6 hours, and the duration of action of this drug is lasting for about 18 to 24 hours, and it is cleared through the liver, and 1 to 2 doses are administered based on the severity of the diabetic condition at the dose of 5 to 15 mg of each dose. Glipizide is a drug which is having the T half of about 3 to 5 hours, and duration of action is lasting for 12 to 18 hours. It is also cleared through liver, and it is given through 1 to 2 doses per day, and each dose is containing 5 to 20 mg of the drug. The other one is glimepiride. So this is a drug which is having T half of about 5 to 7, and the duration of action of this drug is about 24 hours, and it is cleared through liver, and only single dose is given, which involves a dose of 1 to 6 mg. The other drug is gliclazide, which is having the T half of about 8 to 20 hours, and the duration of action of this drug is 12 to 24 hours, and it is also cleared through liver, and 1 to 2 doses are given with a dose of 40 to 240 mg per each dose. The other drug is metformin, which is having a T half of about 1.5 to 3 hours, and the duration of action is about 6 to 8 hours, and it is cleared through kidney, and the dose is given for about 2 to 3 doses daily, and each dose is containing 0.5 to 2.3 grams of drug. And repaglinide, it is having the T half of about less than 1 hour, and the duration of action is about 3 to 5 hours, and it is also eliminated through liver, and 3 to 4 doses because of the lower T half, it is given through 3 to 4 doses every day, and each dose is containing 180 to 480 mg of the drug. And the The other drug is nataglinide, which is having the T half of about 1.5 hour, and the duration of action is about 2 to 3 hours, and it is also excreted to liver, and 3 to 4 doses are given at the dose of 180 to 480 mg of each dose. The other drug is rosiglitazone, which is having a T half of 4 hours, and the duration of action is about 12 to 24 hours, which is cleared through liver, and it is given through 1 to 2 doses per day, each dose containing 4 to 8 mg. The other drug is pioglitazone, which is having a T half of about 3 to 5 hours, and the duration of action is for about 24 hours, which is cleared through liver, and a single dose of drug is given for each day, dose containing 15 to 45 mg. So these are the various anti-diabetic drugs which are administered at different doses based on the severity as well as T half of the drugs.